I want to thank you guys for joining this call. For those of you that don't know me, my name is Dee Sabatis. I am the Deputy Director for USET SPF. Know many of you from my health director years. So excited to see familiar faces on the call. A majority of us just got off a health director call where we talked about similar subjects and current situations of COVID in their communities. As we know, as the media has shown across the country, COVID is soaring at some of its highest levels. And that's very evident in our community at Indian Township. So it'll be interesting to hear some of the updated guidance that our EPI team has put together for us. We will go over some home testing frequency, quarantine and isolation, and then some current FAQs that have been brought to our attention that our staff have put together for you all. We'll also get into some updates from IHS NAO, and I do apologize for those that maybe got the alert for this call last minute. We're working through that email process as well. So we have our EPI team on board. Christy Duke, our senior epidemiologist, will look through some of, or walk through some of the most current updates that we have for you with some formal guidance coming out from our team by close of business on Friday, I believe. So Christy.
Thank you, Dee. I appreciate it. Wanda, can you allow screen sharing? Let me share my screen with you guys. Oh, there we go. I got it, Wanda. Thank you. All righty. Thank you, everybody, for being on this call today. I know that there has been a very rapid change in the rates of COVID with the Omicron variant, and I just wanted to go over a few items with everybody today. I'm going to start out with some data. This is from the CDC, and I found this very, very interesting when I pulled it yesterday. You can see the red line on the graph on the left is the 7-day average of number of COVID cases in the United States, and it's really just skyrocketing right now. We expect that trend to continue to go up in the coming weeks. And I'm going to talk a little bit more in a minute about what we're going to expect to happen in the future. The graph on the right is the variant breakdown, and the purple bar is the Omicron variant, and the orange bar is the Delta variant. There's a black bar as well, but that's fairly minimal of other variants. We haven't seen a whole lot of those, but you can see as we headed into the Christmas break, you know, we're seeing Delta, and then it really hit hard, Omicron, and it came on hard and fast. We had some indication that that was going to happen both out of the UK and South Africa. Those rates rose incredibly quickly, so we sort of expected that, but it was a very, very rapid change in that shift over from Delta to Omicron. I want to talk, before I get into even more data, I want to just briefly touch some highlights regarding Omicron. I know we've all heard that the disease is milder than Delta or the original variant, but we still need to be very vigilant. Right now, it can still be very severe disease. We're seeing hospitalization rates go up. Long COVID is always still a possibility. And even if you have fairly mild disease, you can have long COVID, and that can have both just annoying consequences like the loss of smell, or, you know, longer term, more serious consequences. So that is still a definite possibility. I think amongst public health folks, one of the biggest concerns is spreading to the vulnerable, like children or elders, especially those the children that are unable to be vaccinated at this point in time. I think another very large concern is the healthcare stress. So if this is obviously more transmissible, I think one of the things that we're concerned about, even if you have a healthcare worker who is not very sick, they still can't come to work. So if you've got a lot of healthcare workers out due to Omicron, even if they're not really sick, that's compromising patient care right there, because we don't have enough healthcare workers to provide comprehensive care. And I think one of the other main concerns as public health officials that we're concerned about, every time the virus copies itself and reproduces, there's a chance for a mistake in the genetic code. And that means anytime there's a mistake, that is a mutation. And so the more it copies and the more it spreads, the more chance of mutations, and we don't know what that will bring in the future. So we're really warning everybody to still be vigilant about Omicron, continue instituting those public health measures that we know work, and don't let your guard down, even though this does seem to be a milder illness. Here are just some results from the area office for the last week. This came out in the weekly report that we sent out to everybody yesterday. And this is just reflective of the graph that I showed you a minute ago from the CDC. As of last week, there were 845, or as of the 11th, actually, my apologies, there were 845 positive tests out of the Nashville area, and those are the reporting facilities that are reporting to IHS. So I know not everybody is reporting. I expect those numbers are probably higher because of that. So there's a lot of cases out there, and you can see, you know, at the beginning of December, we were in the 70s, and then we dipped down briefly to the 40s and was staying in the 60-ish range prior to that. So we're seeing a very rapid jump, and that's really no surprise given what we're seeing across the nation. So we know that it is in our communities. I know you're seeing it. I know you don't necessarily need a graph because it's all around you, but that's currently what's going on in the area office. This graph, this group of charts, I really, really like. We pull this data from the state, their state websites every week, and we to compare what's going on within the states to the tribes. And you can see every single state, with the exception of Maine, and I'm going to come back to that in a minute, it's just a very rapid increase. I mean, it's just skyrocketing. I will say with Maine, we do not trust those numbers at this point in time. We've heard, I know Dee has heard from her contact back from her health director days that they are backlogged. And so I expect that that is not a true decline. It is an issue with entering data, getting test results, that sort of things. Dee, I saw you unmuted. Do you want to make a comment?
No, that's just correct. CDC for Maine did confirm it was a backlog in data.
Yeah, so that is not a true decrease. It's a data collection issue. And if you see the USET all state rates, we have a slight drop. That's because of the Maine data. So it's not a true drop. I expect that to in the coming weeks to go right back up. We'll see a dip because of that. So be vigilant. Florida, some months ago, has stopped reporting on their website. They are not at zero. I am, positive of that. So keep that in mind. We also pull Florida out of the USET, the all states rates. That's not included in there since they're not reporting. This is what we're seeing within the PERCDAs. And versus the states versus the US. This is again from the state website. This is not IHS data, but we pull the data from the counties that are included in the PERCDAs, and you can see a rapid rise. 1228 to 14 saw a spike. My guess is that severe of a spike was probably entering data over the Christmas break. There was probably a backlog and they got it entered. But if you look there's just been a steady increase, and then 1214, well, I guess 1130, it starts increasing, and that's going to see a pretty steady increase. I would caution you, do not interpret 1.4 to 1.11 as a decrease from the previous week. I think that that's we call that a data artifact. And that's just, again, because of backlogs, you saw that rapid spike. Look at the trend over all of those weeks in there when interpreting that data. I would like for you to really view Omicron rates rising as an early warning. This was a really great article in the New York Times. Kiki shared with me a few days ago, and we thought it was important to bring to your attention. I have the reference down at the bottom that it was January 7th, and it's how to think about COVID data right now. I do encourage you to read that if you get the opportunity. So, what I said earlier, it is a less severe disease, but we still need to view it as an early warning sign. The rates are growing, as we said, they are likely undercounted. And there's a lot of reasons for that. Because it is less severe disease, people may not be going to get tested. They may not be feeling sick, so they don't even go in. As well, up until fairly recently, people have been home testing. I know that there's been some availability issues going on, but if people get a positive test at home, they're not necessarily going for a confirmatory test. So those home tests are not reported. So we really suspect that this is underreported right now. Again, it is less severe, but it's so much more transmissible. As I mentioned before, we're already seeing the hospitalization rates surpass what we saw with Delta. Now, I want to give a warning about hospitalization rates. Because this is a milder illness, we are unable to tease out hospitalized with COVID and hospitalized for something else and also have COVID. That from a public health perspective, that matters, and it matters and it doesn't matter. And I'm going to explain that. We want to know the burden of COVID and what's going on and how people are sick and how it's affecting them, and the complication rates, which would be the hospitalization rates. We definitely want to know that information. However, as I said, you can't quite tease that out. So that's becoming a little bit less reliable. That said, the fact of the matter is people are testing positive, and they're testing positive and they're able to transmit. So that burden is within the community. And so then you have greater spread. Really watch the hospitalization rates and keep both of those factors in mind. The ICU rate is really what's going to tell us about the severity. We've not seen that increase quite yet. It's coming, we suspect, because there usually is a little bit of the delay before people develop severe complications. Omicron, we're expecting it to spike sooner than other variants. And that can be both good and bad. Again, getting it over with quicker, but a quicker spike means that more people are burdened. And what I mentioned earlier about the continuity of care and the effect of the healthcare workers in the healthcare system is potentially very great. I know I've heard a few anecdotal reports from friends and family who have had to go to the ER in a few places, and they're at capacity. So, just keeping that in mind, let's take that as an early warning that, and this is a quote from the New York Times article, that we need to adjust both our behaviors and policies to reduce infection and to protect our most vulnerable. And as we know, that's elders, children, immunocompromised. So there's some upcoming documents that I want to talk about. We are going to send out by close of business Friday, guidance and recommendations, quarantine and isolation. That is, quarantine and isolation is, let me just give a very brief recap of what those are. And this language is becoming more and more important. I know that public health people and lay people have been using those interchangeably quite a bit. They are not interchangeable. Isolation is the restriction of movement of a person who is infected, whereas quarantine is the restriction of movement of those who have been exposed. And I think that's going to become more and more important as we continue down this path, and not to use those interchangeably. So USET looked over the CDC guidance that came out about changing the isolation period to 5 days and masking for 5 days. We looked at the studies behind those, and we really dug deep. And I think that we're going to recommend a more conservative approach than the CDC is recommending. I think we feel that with the population that we serve, it might be wise to just be a little more cautious and continue with the 10-day isolation recommendation at this point in time. That said, we realize that that's going to be very difficult, if not impossible, for some tribal nations to institute. And we are always available if you need to talk through what your measures are going to be in your community, and we can help you to develop specialized measures that would be appropriate for your community as you see fit. We are also going to be releasing guidance and recommendations regarding home testing. Hopefully the amount of home tests out there is going to increase. And what can people do to utilize home tests to keep themselves safe and to keep their families safe? So things like testing before they have a family get-together, a small family get-together, or have people coming into their home that are not household members. So what are some of the things that they can do to help protect themselves? We're going to issue some updated FAQs, including the vaccine effectiveness. As we know, it appears that the vaccine is not as effective for Omicron. That said, we need to make sure that people understand that, but also understand that natural immunity is not as effective as the vaccine as well. I know that there has been some talk about having COVID parties, like they used to have the chickenpox parties, and caution against doing that, because that it may give a false sense of security, and it's probably not the safest practice at this point in time. In addition, you may recall emails we sent some months ago. We contracted with an agency to do focus groups on vaccine hesitancy. Those materials are ready and should be coming out Friday with our send, really targeting those that are hesitant to get the vaccine. And I know what we hear in the media, and vaccination has become so contentious that we think that there is people who are either pro-vaccine or con vaccination, and no in between. But those in between folks are still out there. Kiki, go ahead. I see your hand raised. Sorry.
That's okay. Can you hear me?
Yes.
All right. I just want to underscore what you just said a moment ago about the COVID parties and express our concern about the growing stories about that. So the idea of just getting it and being done with it is spreading not only within the anti-vaxxer crowd, but even, just more broadly, that's spreading as an idea, as a good thing. But if you could just go back to slide 2 for a moment and just pull that back up and just underscore those points. These still linger out there, and these are still strong possibilities and concerns that if we just give into this and think that we're just going to get it and be done with it, that's not a correct way to think about it. So I just want to underscore those 5 points that you addressed earlier. And then to your, secondly, to your earlier point about the math associated with this and the transmissibility. So yes, the severity may be less, but from a pure numbers standpoint, more people are getting it. And then from a pure numbers, it's just as great a concern. So I think people are getting too comfortable with this idea that it's not as severe, and relaxing back on some of the things that have been being preached now for 2 years. So I just wanted to just take a moment to underscore and remind people of the importance of these 5 points that you covered earlier, directly in correlation to the spreading thought about, quote unquote, COVID parties.
Yeah, thank you, Kiki. I appreciate that. Kiki always serves as a opinion for opinion of a person outside of the public health sphere that I always value, because he brings me back to outside of the scientific thinking that we often can get into. And I think that that's a really good point. And this slide right here reflects that. This was actually another New York Times article, and I believe it was in the agenda. And the fifth point of the article was don't test Mother Nature. You know, that's always a bad idea. And I changed that a little bit to specify, to be more specific, because what we're doing when we test Mother Nature like that is we're increasing the chances of mutation, which potentially can increase the severity of the disease. We don't know the direction this is going to go. So thank you for that, Kiki. So, and as I mentioned, the vaccine hesitancy campaign, those people that are wait and seers, that it's just not that important to them, that just haven't gotten around to it. We don't hear from them, but they are still there, and we have got to reach those people. So we will send those materials out, and we will also have a social media campaign, and it's really geared towards tribal citizens in our area about getting vaccinated and the importance of that. A lot of those messages, or the messages that are in those materials, were tested, so we're really hoping that that language in there really speaks to those people. And I had this predicting the future slide in previous presentations I have given to you guys, because there is a good deal of prediction in this job, especially in a pandemic situation. Eventually, we are going to shift from pandemic or epidemic. And if you recall, that's having disease that's greater than what you're used to seeing either within the community or in multiple communities, to endemic, which just means kind of the background circulating disease. Strep throat is endemic. The flu is now endemic. Chief Malerba, let me unmute you. You've got your hand raised.
I didn't mean to interrupt you, but I just, thought I'd raise my hand. I'm sorry for attending late, but one of the things that, I just wanted to ask is, do you think that the CDC is going to say that being fully vaccinated means being boosted? And I will share my own experience with you on that, because I think that this is really important. We've been lucky and fortunate that we have been participating in antibody studies. And so initially I had 0 antibodies, and then I got vaccinated and my antibody level was 1.98 3 months after I was vaccinated. 3 months after that, it went down to 0.92. And then I got boosted in November. A week after I got boosted, my antibody level was 2.87. And so I really, number one, it's good to have the information. I'll be curious to see what, my antibodies are like in February. But, I wonder if the CDC is considering, making that statement. And the other issue that I saw even today in the New York Times, they were talking about how the virus only lasts 20 minutes once it's spewed into the air. But the problem is that people aren't wearing their masks and they're not staying far enough away from people. They're not socially distancing. And those are the two things that still make, a big difference in keeping people healthy. So anyway, so that was my question. Do you think the CDC will change their stance on that?
So I'm going to unmute both Dr. Johnson and Dr. Brown on this. I know Dr. Brown, that's going to be in our recommendations. Let me hold on just a second, Dr. Brown, about the fully vaccinated questions. And we've gone back and forth about what we think the CDC is going to do. I think our position is we need to have fully vaccinated be boosted people. That needs to be the definition of fully vaccinated. Dr. Brown, do you have anything to add to that?
Not really. I mean, the CDC has, what's their compromise definition? Up to
Up to
date.
date,
Thank you.
yes.
Yes, that's exactly right. So if you're up to date, it means you've had the primary series plus a booster if it's time for your booster. But once again, they're being very nuanced in their communication, but it, I think, is kind of confusing for people. The bottom line is if it's been long enough, that is 5 months since you had the primary series, you should get a booster.
Yeah, and it's also too that you can take a sovereignty approach. The CDC gives guidance, we give guidance, but tribal nations can develop their own policies and their own positions on that. And we're more than willing to be a sounding board for that should you need to. So any of these measures, isolation, quarantine, surveillance testing, group testing, any of those things we can talk through should you need it. Chairwoman has her hand raised too. Let me find her.
I don't know if you can hear me.
Oh, yes, we can.
Oh, okay, great. Thank you. Thank you for this. It's thought we'd be out of these meetings and these calls by this year, but apparently not. And it doesn't look like it's going to be changing anytime soon. I think to your point, Christy, that as sovereigns, we really need to be a lot more proactive and a lot more stringent with how we believe it's going to protect our people even more, using the CDC guidelines as the floor minimum. Only because we know that even early on, they have to protect the entire United States population, and they were not very forthcoming and genuine with the guidance that they should have been giving early on, which was what we adapted to, which is immediately going to mask, immediately going to the safe social distancing, and immediately, retreating back in to stop the spread, and recognizing that, you have to apply a little bit of common sense to this, as well as what the guidance is. And we're responsible for our people that we are directly connected to. So I think it's, for us to be able to err on the side of caution, on more extreme caution is a far better way for us as tribal leadership. The other thing that, we're having a struggle with is, ample home tests. And I think I saw something in the chat that, the national stockpile may not be noting a shortage or anything else. But we've got 2 instances in our community where we have our island and what is administered out of our clinic that services our people that are right here on the island. But we have an overwhelming need on the other side where we're also responsible for servicing our people. So being able to get ample testing supplies and doing the good practices. Our children are the most vulnerable. The school system here on the island has taken this novel approach, and I'll use that term very loosely, because they're not doing their testing. They're not requiring, all of the rest of they're taking the base minimums of precautionary factors. And we're having a spike on the island. We're having a spike in our office. We're having a spike in our community. And so we really need to be able to be far more assertive and far more protective of our community members than what our surrounding communities are advocating. So that's where we're trying to get, access to more tests for both places. And, maybe, I don't know, and I know that, IHS can't always go beyond what the CDC is providing as that government entity. However, having, even if it's a more informal guidance that is being drafted so that it gives the tribes a little bit more gravitas when we go to the school systems or wherever we need to say, this is what we're doing for our communities based upon, our rights as sovereign to protect our community members. Because the problem is that if the school systems aren't doing the right thing and they're putting our children in peril because, we're all in the public school, well, 90% of the students, tribal students, are in public schools. So if we need to advise our parents on how to better protect their children, we can't have our children penalized academically. or within the school systems for following protocols that we believe are going to keep them safer and more protected than what the local municipalities and or systems are doing. So we're walking a fine line, and you guys are kind of in the middle of it, but it gives a little bit more gravitas for those that don't understand that we have these rights, but we seriously have to do what is best for us. And I'm glad that Chief Minerva mentioned about the antibody testing, because I had asked for that last year to see how our community was impacted and or responding to COVID, the original, so without having the ability to see who has had it, because the early testing was only in severe cases, and then it got looser. However, now we've got the home tests that aren't being reported because there's no way to control that, and there's no way to be able to know what's going on. So we have no idea what this spread is, to your point with those graphs, and we have no idea what the long haul symptom impacts are going to be, which my husband and I constantly talk about how we're fuzzy this and don't smell that and everything else, that we knew we had COVID based upon all the symptoms that we experienced, but we weren't hospitalized. But now we just don't know because there's no way to verify that. So we're not included in that number, but we know from what we experienced that we had it. So these numbers are so skewed, there's no way to really pinpoint it, but what we have is frightening enough. So, we just need to know and start anticipating what those long haul symptoms are and the health impacts of those, because that's going to impact our IHS dollars in the long run as well. So whatever we can do to also promote getting antibody studies done to see how we're doing, and just general health is going to be my next priority for our community, to see just what's going on in our community's health, because it's all going to impact us. If it's not this year, it's within the next 5 years, we're going to start seeing what those long haul impacts are. But thank you for all of this work, and I can't wait to get some of the documentation or the pamphlets or the information that you're going to be sending out, because it is important that we have it and we can post it on our websites as well as send it out. Thank you.
And Chairwoman, I just would like to say any of that guidance can be tailored specific to your tribal nation. So, we're kind of like the CDC in a sense that we have to address everybody's needs as best we can. But if you need to work with the epicenter to work one-on-one to tailor specifically for your tribal nation, we're absolutely available to do that.
That would be wonderful. And I know that, our PRC supervisor, Ryan, Chief Melanson is on, and I know, or I'm sure that our folks were on the earlier call. But yeah, that's going to be something that is, we have to look at. We have to look at it through a couple of lenses, both here in the bubble on the island where there is no escape, and then on the mainland where there's just total exposure in these very, very high rates as well. Thank you.
Thank you. I'm going to turn it over to Dr. Johnson with this parting thought about predicting the future. This is not going away. We're going to shift to endemic, to where, COVID-19 is not considered a pandemic or an epidemic, that it's just background circulating. That happened with the flu. I believe that was mentioned on a call yesterday, that there was pandemic flu, 1918. And since that time, we've shifted, and flu has just become part of our landscape every year. We have flu shots and we have antivirals, and I think we all foresee that happening with COVID-19. We will get better at managing it, just like we did with the flu. And there is some hope. Novel diseases, that means new diseases, oftentimes, not always, but often, as time progresses, a lot of times they get less severe. So we do have some hope moving forward. But with that, I know that Dr. Johnson has some specific updates with things the area office is doing. I know that Kiki had a question on the home test and the distribution. So I'm going to go ahead and turn it over to her so she can give you those updates.
Good afternoon, everyone. Thank you, Christy, for that. As I listen to you all, I'm reminded of, where we started and exactly what you all are saying about thinking by now that we would be in a different place. And, unfortunately, we're in another surge, and we are working very diligently to try to get the tools out that you all need to protect yourselves. I do want to mention something before we go into resources from IHS that we currently have available. I do want to go into the influenza vaccines because I know that it's flu season as well, and there were some conversations related to the ordering of flu vaccines for the next one. So I wanted to, and that'll be in your health director's update, about the fact that the deadline for ordering next year's influenza vaccines from NSSC is coming up. So currently, IHS is doing, and Nashville area doing several different things. And I know there's been questions about home tests. I think Kiki asked that question about where we are on home tests. I think there was a hiccup along the Christmas holidays or right after the Christmas holidays related to ordering of those home tests. There were several sites who ordered home tests and they did not receive those tests. And so we ended up having to talk to NSSC about reordering those tests. We have since reordered those tests, but those tests were not the quick view. The quick view right now, while IHS has several different tests to include the Abbott ID, the BinaxNOW, and the quick view, we are currently recommending that you really focus in on the quick view. I think the quick view is one that the NSSC actually has, and it's not coming directly from the distributor. Our Abbott ID and our Binax may be delayed in some areas because while we're saying we're backlogged, or we're saying we weren't backlogged, we're starting this week to start seeing a backlog. NSSC is sending out all the supplies that they have, but they also are getting shipments out from Abbott ID directly too. So if you're ordering and you did not get your BinaxNOW, please let us know. I know several sites have told us, and we've contacted NSSC and they've resent those out. I know that I spoke with Ms. Spain, and I think that there was some confusion as well with their testing where they were getting ready to really need Abbott ID now. And I think hopefully they've gotten that yesterday, but there was the quick view versus the Abbott ID. So hopefully we've gotten that settled, but I'm gonna encourage everybody to keep plenty on hand. And I think if you're talking about flow and which ones you're not gonna be limited to, I would say right now it would be the quick view test.
Dr. Johnson. I'm sorry, this is Kiki. Thank you for that update. Can you clarify for me? So that sounds like those were home tests ordered directly by IHS and the backlog associated with that. My question was specific to the presidential announcement of the hundreds of millions of home tests that were supposed to be distributed across the country. Are you guys getting any updates on the status of that distribution as well? Or are they
I don't have any updates. I've not seen any recent updates, but I can follow up.
Okay.
Sorry, that was not the question you were asking.
No, that's okay. That was a good, valuable answer anyways. Is it your expectation that broader individual household distribution is going to come through IHS as well, though?
I think I think that as a result, each agency, each agency, that's why I said about the quick view test, each agency has an agreed upon amount that they will continue to get, but I don't think that is tied. I think that's separate from what Biden is doing. I think it's specific to the agency. So I don't think it's tied into it, to answer your question.
Okay, thank you. Sorry.
Oh, that's fine. I also want to talk about therapeutics because I know there's been some questions about therapeutics, and I think some of the updates have talked about the therapeutics that we have available. IHS has limited numbers of therapeutics, and the great part about it is that we have some that are oral. Starting off, we had the monoclonal antibodies that were IV, and then they were IM, so that limited a number of sites' utilization of those. But now we have two orals that are available, but we have a very, very limited supply of those. And how we are looking at distribution, we are asking, and I've reached out to several of you all about making sure that you update us on your positivity rate, because we're looking at your positivity rate to help guide us in the distribution of those therapeutics. And again, it's a percentage positivity and not an actual number, meaning that if you have 30 positive, but you have a smaller tribe, then it's not going to affect you because you don't have the 500 positives that another tribe has. It's looking at the percentage positivity. And I know that there was some lag in getting that information out there. We're also asking that if you would like them, that you continue to request them, send emails to request them. You can request them through me as well as Robin Bartlett, who's our area pharmacy consultant. We are taking a look at looking at, people who are requesting them, looking at the percentage positivities, and then also looking at what you have on hand. There is a data bank in which you're going to continue to report what you have on hand, so that we can follow that and determine as we're distributing what that looks like. And I'll have to give you all that at a later date in my update. What's that data bank? This is the same one where you're looking at your VPOP system for your vaccinations. PPE, I reached out to several of you all looking for any PPE needs. I think most of you all have responded via email or calls, but there are a few that I've called and left messages that I have not gotten a response for. But our Nashville area office has ordered PPE. So we have gowns, we have gloves available, all sizes. We have N95 masks as well as surgical masks as well that it's available. And so if you're in need of PPE, please let us know so that we can actually get those out. We have done an allocation to each tribe, but we will send those out as needed. So please don't hesitate to reach out to us related to that. Wanted to also mention, I think I may have mentioned it on a previous call about the visiting of sites related to vaccine administration by CDC as well as state. And some of you all may have already been contacted. I don't know what those sites will be and what that looks like, but the plan is between now, I think in March, that they will visit several sites within the IHS area. I do have a call with CDC every other week. And so I did ask them if they are aware of any of the sites within the Nashville area that will be visited. Please give me heads up and I will let you know. So I say that to say that lots of things have changed as far as administration of vaccines and keeping up with vaccine competencies. And that's just making sure that the person that is administering vaccines and handling the vaccines have been trained on that. And so there's vaccine competency checklist and several other documentation records that have changed. And so we want to remind you all to make sure that your sites are up to date on that, because those are things that they will be looking at as they are coming through and looking at your vaccine program related to your COVID vaccines. There are several trainings that are out there. We've been sending emails out related to the different types of training available. I know you all are probably getting bombarded with our emails as well as a lot of other emails, but we try to get it to your health director and your nurses related to that training. I think a couple of days ago, there was a training on vaccine competency as well as mitigation strategies to ensure that best practices to ensure that you have risk reduction and reducing the number of errors. There's also, there was a training yesterday related to the oral antivirals, as well as some upcoming training related to outpatient, the other therapeutics. So there's a lot of training that's out there. So I know you all have lots of emails and your health directors and nurses are, but please encourage them to read those emails that are coming forward, because a lot of useful information is in those emails that will kind of help you as we continue to administer medications and do our testing. I am hopeful. I know I've taken up a lot of terms. I do want to mention that there was a question about what would be up to date versus what that definition would be. And I think Dr. Brown did a great job at covering that information on fully vaccinated versus up to date on vaccines. And again, those first two vaccines are where they're going with fully vaccinated, and any boosters that are recommended for different age groups, that's when they use the terminology of up to date on your vaccinations. There's a lot, and I won't go into it, but there's a lot of changes related to who can be vaccinated, but we truly have just about current recommendations is anyone 5 and older can be vaccinated, as well as the boosters. I think there's a lot of information that's out there and we can provide that. I won't go over that on this, but it is really important that for those who are able to get boosted to do those, because like it was said earlier, it does help with your antibodies and help you in fighting and the transmission. So continue to encourage your families to social distance, wear those masks. And I know that there are some questions about masks and what's the appropriate mask. And now, CDC is saying that a single layer mask is not protective. You need multiple layers, at least 2 layers. There's some questions on if they're going to say N95 versus medical grade. So that's still all up in the air. But the big thing is just making sure that you're masking appropriately and that's your nose included. You'd be amazed at how many people I'm still seeing with masks that are just covering your mouth. Making sure that we are washing hands and socially distancing. And I think we sent some information out about homes, disinfecting your homes, as well as that how you can protect an individual within your home that may test positive for COVID. So I know there's a lot of information we're sending out, and I apologize, but we really tried to send out important information and not just, information for the sake of sending it. So if you can make sure you can help me with that distribution, and make sure that if you're having new health clinical directors or nurses, et cetera, to contact us so that we know that you have someone that's new and we can make sure they're on our listserv so that they're receiving those emails. With that, I'll turn it back over. Thank you all. Dr. Cotton.
Chairwoman Andrews Maltese, I believe you had some comments or questions.
Yes, thank you, Wanda. And by the way, Happy New Year to all y'all. Nice seeing everybody. I was just going to go back to the masks and the PPE. And I was just wondering whether or not from either the national stockpile or with the ordering, and there was an announcement or some sort of feature that did highlight that the best use is the N95. My personal favorite one, the turquoise one, was the one that they actually showed. And I was just wondering whether or not you're seeing any sort of supply chain issues with regard to that, because of course, we're not getting anything through the states. And I was just wondering whether the states are just simply not engaging, or at least our state is not engaging us with any allocation for our tribal population, mainly because they might view it as the same way as we went directly to the United States through the Indian Health Services for our vaccines and not through the states. So no fault of theirs, they might be looking at it through the same lens that, tribe's on its own. So while we're not going to give back the allocation based upon the census, because the tribal census population is included in that, they're getting their own. And we just want to make sure that we have ample supply of these, of these masks and everything else, because the states and the local municipalities really are not including us in their allocation counts.
Thank you for that question, Chairwoman. So as I spoke with several different tribes, I think they have gotten allocations from FEMA. And so when I talked to them about their need for PPE, they talked about either still having PPE from the bulk that Nashville area sent at the beginning and still having a lot of that, or having recently worked through our Trans Am. I can tell you that we've ordered a lot of PPE and have it available and allocated. Should we, find the need, you also can order still through NSSC. They have PPE as well. I hope that answers your question.
Dr. Johnson, there is a question in the chat about if you could recommend vendors for KN95s. There's a lot of counterfeits out there is what's being said.
There is, and there is a website I can send you that the CDC has that has the FDA approved, if you will, or FDA, they're listed on the FDA website. I guess FDA approved, the language has to be a little different. But I honestly don't recommend at this time that you're purchasing because they're available. I think that we are so limited on our resources, and there are other things that you're going to have to, really purchase that, if you would like, you could order them through Nashville area office. Because when I look at the distribution allocations, they are pretty high numbers of allocations. I think that we should be able to cover any needs. And if we can't, NSSC is definitely a backup. So you can get that information if you would like. There's a website on the CDC that gives you the list of those companies that have those who've been accepted by CDC, but we also have the ones that we have been accepted as well.
Thank you. Christy?
Yeah, Dr. Johnson, I'd just like to make a note on masking. I think what's being reported in the media and what people are interpreting about masking is that cloth masks are useless. They don't work. And I just want to caution people against that thinking. Yes, they provide little protection to the wearer, but they still work in containing that virus getting out and spreading, which is one of our main goals. That said, the KN95s are going to be important. We also now, because it is so transmissible, we want to protect the wearer as well as, the community as a whole. So, if people don't have N95s in hand, those cloth masks they're not useless. They still do serve a purpose. And I'm seeing that language and that thought out there and just really cautioning people against that.
Or continuing to use the surgical mask that we have been using, because I think that's one of the messages that the main CDC director had mentioned, that those are still good masks to utilize, and not to just try to get off and order the K95. The price gouging is in effect for sure.
Thank you, Dee. Yeah. Either the surgical mask, the cloth mask, masking is still a good public health strategy. Do we need to improve the masking? Yes, we do. But that doesn't make our previous strategies useless either. So. And
do we have any other questions for our USET EPI team or IHS and Nashville area office? I see Mike's video. Oh, he's he's still on mute, Mike.
Sorry, I tried to hide, but you caught me.
Well, hearing that, I know Kiki did put an update on the mask question that he had to Dr. Johnson regarding the president's announcement for the 500 million COVID tests, not the mask, the COVID tests, and then the additional 500 million on top of that. So that's in the chat as well. I haven't had an opportunity to read the long version, but I know it's in there if you wanted to talk to that a little bit, Kiki, if you're still on.
The longer version is separate, Dee. That longer version is about the N95 mask and the possibility of the administration making N95s available as well.
Great, thank you. Any additional questions? Okay, hearing none, I do want to thank you guys for joining the call. This is being recorded, so we can send it out to the folks that didn't have an opportunity to join, or your staff that may want to view or hear the update. Again, the EPI team will be going out with some guidance documents by the end of the week, in hope that you can utilize those at the local level. So hearing no additional questions, we can go ahead and adjourn for the morning. Good morning, yep. And I do appreciate you attending. Thank you.